on behalf of the TRP and the Department of Laboratory Medicine and Pathobiology, I do want to say thank you for coming. These are opportunities for our students to share with you what they've learned, how, what they've been through in terms of their last, the year, and how their projects have developed and how they've been able to apply the knowledge they've gained through this program. So it's a real opportunity for actual knowledge translation. So thank you for coming and supporting. And with that, I'm going to be quiet and pass it over to Adita.
So I was going to introduce myself. So my name is Adita Markar, and I facilitate students learning in the Capstone projects for translational research, and I will be chairing this defense. So thank you, Joseph. It is with great pleasure that I would like to welcome the students that are presenting today. So Dorothea, Mona, Stephanie, and Andres, and they will present their capstone journey. Their project is titled Roadmap to Bridging, Developing and Unifying the Discharge Process. And they're gonna tell us all about it, how they came to this project in general and how it was working out for them. I would also like to welcome the members of their advisory committee who gave the team their time, expertise, and guidance for this project. The members of the committee are Andrea Vadel, who is an assistant professor at an acute care psychiatrist at CAMH. She is the divisional lead for the quality improvement and innovation at CAMH and is driving research aimed at examining patient safety in acute mental health services. Andrea is the team supervisor at CAMH and really the main, their primary point of contact at CAMH and their advisor. And Andrea has really been a great mentor for the students and spent a lot of time on the project. So as a TRP, we really thank you for your time and commitment. Oliver Sanser is an assistant professor in the Faculty of Information at the University of Toronto, and Oliver's research interests revolve around human-computer interactions. Thank you for being part of the committee. Sophie Sokladaris, I'm not sure if I'm pronouncing it correctly, sorry about that, is an interim director of research and education and a senior scientist at CAMH. And Sophie's research examined the inclusion of patients and their families in designing and implementing hospital practice. Melissa Hebert serves as a patient engagement and research coordinator at CAMH. So thank you, Sophie. Thank you, Melissa, for being part of this committee. Other members of the examining committee include Douglas Templeton, who is a professor at the Department of Laboratory Medicine and Pathobiology, which is where TRP is housed. He also has an MD from University of Western Ontario, and he will be serving as an LNP representative for this defense. We also have Zoe Finley. Hi, Zoe, which is who is our alumni from TRP, and she will be serving as the TRP community members. So last but not least, we will welcome the fellow faculty members at TRP. So Joseph Fehrenbach is a program director, but he's also a supervisor for this particular project. Again, thank you all of you for being here, for being part of this defense. I think we have 27 people here, so I'm glad some of the first years and actually second years join us for this first defense of this cohort. Before we begin, I would just like to say how this is going to go. So basically the team is going to present for 20 minutes. At which point there's no interaction, no interruptions, no questions. After the presentations, the committee members and those on the examining committee will have chance to ask the team questions. The way we're gonna do it is we're gonna go with 2 questions per person, so either the committee member or others in the examining committee. And then if we have time, we can go for another round. After that, the examining committee will go into a breakout room where we would deliberate if the team did enough to warrant them their master's degree. So, and then we come back and we let the team know. If you have any questions, please ask me. No questions? Okay, so welcome. And we are here to hear all about your project.
Thanks, Edita. Just getting the screen share up. There you go. Echoing Edita's comments about our fantastic capstone committee. Pictures are right here. Thanks everybody for coming out to support us today. So thanks for attending our roadmap to bridging, a quality improvement project with the Bridging Clinic at the Center for Addiction and Mental Health in Toronto. Joining me on the Capstone Care team are Andres, Mona, and Dorothea. We'd like to start with an overview of the project mapped onto the stages of the Toronto Translational Framework. Initially, a backlog in discharges from the Bridging Clinic was identified as an area of need of improvement by both clinic staff and leadership. So to improve access to care, there was a need to address the discharge process. Through a mixed methods approach, we performed a needs analysis to help define our project and identify the root causes behind the backlog. Needs were uncovered, selected, then verified with the Bridging staff and leadership, and this led to the development of an intervention and method for evaluation by clients and staff. The funnel shape of this framework is not accidental. We will share with you how we started off broadly in discovery and narrowed down to the translation of our findings and feedback into a prototype called Roadmap to Bridging, a tool to help clients and staff work together to set actionable goals for bridging. In 2018, the World Health Organization defined continuity of care as the degree to which a series of discrete healthcare events is experienced by people as coherent and interconnected over time and consistent with their healthcare needs and preferences. We selected our project with an interest in the lack of coordinated and continuous care in the mental health care space, as it is a significant challenge that greatly impacts the delivery of care and the patient experience. Established in 2017, the Bridging Clinic aims to provide low barrier and rapid access for acute care post-discharge from mental health and addiction services. Clients may come from Bridging from other CAMH services after being triaged, assessed, or discharged by the emergency department, or discharged from an inpatient unit. The services included in Bridging are designed to ensure that clients are bridged to other CAMH services, to the community, or to a primary care provider and not lost to follow-up over a maximum 3-month period per episode. Clients access Bridging for many reasons, including for prescription refills, assistance to complete government forms, or to get a referral to suitable treatment program. Bridging staff is composed of a leadership team, administrative team, the clinicians who are social workers or nurses, and the physicians who in this clinic are psychiatrists. Clients are unable to schedule appointments and access the clinic on a drop-in basis. While it's the intention to provide continuity of care while longer-term solutions are found, a client may see different clinician or physician at each visit. Consequently, documentation surrounding a client may vary among providers. So we highlight a key learning here. In the early stages of our capstone, we completed the training and onboarding requirements to become research students at CAMH. In this role, we were able to fully engage with the environment. When we analyzed the Bridging monthly reports, we learned that there is an increase in the total number of clients served, but a plateauing of the rate of discharges over time. This is important because without discharging clients, Bridging is unable to support new clients and help alleviate ED volumes. During COVID, the backlog of clients worsened, further disrupting the flow through Bridging. These data, however, do not pinpoint the root cause for the backlog. We set out on our capstone journey with the following objectives: to examine the current discharge processes and practices and resources at the Bridging Clinic to identify the barriers and gaps, to understand the stakeholders' experiences with the process, to explore discharge processes throughout the greater CAMH community, to complete a root cause analysis of the discharge process, to identify the fundamental need that lies beyond the clinic-generated metrics reports, and to develop a prototype to help address the uncovered need at bridging. I'll now turn it over to Andres to describe our project approach.
Thank you, Steph. As we set out to identify the fundamental need behind our problem space, we initially focused on the research question that would guide the process. This is how we arrived to what are the discharge process experiences of clients and staff at the bridging clinic. The answer to this simple yet complex question would provide us with a deep understanding of the processes and relationships responsible for our problem space. Like with any research question, the second step was to write a protocol and get it approved by an independent committee. In our case, a Quality Projects Ethic Review Committee. In the protocol, we identified how and where the information required to answer our question would be obtained. We had many primary sources of data to exploit, and one critical secondary source that helped us overcome the unexpected hurdle of not being able to obtain the clients' voices directly from them. Sorry, the slide is not changing in my screen. The key takeaway here is that all the knowledge we generated was based on a mixed methods approach. The mixed methods approach allowed us to benefit from many types of analysis, ranging from the classical descriptive and inferential statistics to the 5 why processes to uncover the root cause of the problem between the two extremes. We also experimented with direct observation, interview coding, and analysis. Affinity diagrams based on those codings and document critical assessment. Once again, please, I don't know if it's my computer. The hidden gem of this approach was the constant change of roles within our group. Steph started leading the qualitative analysis to later hand over the lead to Mona and the skill set she acquired in her UX course. Meanwhile, Dorothea's meticulous analysis of all the bridging documentation brought order to the chaos of information we had at one point. And I also had the chance to lead during the quantitative side of the project. From all the analysis, we draw multiple insights. I will showcase the most remarkable ones. The first one was the lack of a unified discharge process. We found from formal interviews and informal talks that the roles and responsibilities of the bridging staff were blurry, which led to a lack of accountability and ownership of the discharge journey. This was also reflected in the training manuals where no unified discharge process could be found. All this generated a lack of clear guidance, lack of engagement from the clients, and extremely variable client experiences and outcomes with the discharge process. The second insight was the inconsistent alignment of staff. Here, alignment specifically refers to the information conveyed to the client by the staff. This was a clear theme present in the 2021 Ontario Perception of Care tool for mental health and addiction survey. The OPAC is an evidence-based tool that standardizes how mental health services obtain client perception of care, feedback, and they use it yearly. They then use it to make valuable service improvements. This was our surrogate for the clients' voices. The inconsistent alignment hereby reflected led to a lack of clear message regarding the clinic's purpose and the importance of discharge to this purpose, and once again, threatened the client's engagement to the care plan and their continuity of care. One key learning from this insight is that even when your ideal situation is not possible, in our case, direct access to the client's voice, you have to be flexible enough to find suitable alternatives that can help you accessing their knowledge. Had we convinced ourselves that there was no possible surrogate to direct client interaction, we wouldn't have been able to gain this insight. Finally, we wish to highlight a question raised by the bridging staff. We were told how certain clients fell through the cracks of the system, secondary to not fulfilling all the required criteria to be eligible for referral to outpatient clinics. Some believe that the accumulation of these type of clients could be behind the backlog. However, when this hypothesis was tested, no difference among diagnosis groups, gender, or age was found when assessing the length of stay in days or the numbers of visits to the clinic. After zooming into these and other insights, we subjected the problem statement to the 5 why process. This process is a simple and straightforward method to identify the root cause of a problem. The critical step behind using the 5 why methods approach is to have a wholesome understanding of the problem and the characteristics and processes surrounding such problem. After several runs of the method considering different angles and insights, we arrived at various root causes related to our problem space. We then proceeded to generate need statements from those root causes and place them in an impact feasibility diagram that helped us zoom in on the most impactful and feasible needs to tackle within our capabilities and constraints. At this point in our project, the overflow of information made us feel paralyzed regarding our next steps. Using these tools to distill the critical information into simple need statements and later rank them in a way that reflects its relevance and feasibility helped us become focused and to easily determine what was our next step. Hence, when looking to move forward after becoming a subject matter expert, narrow your focus to identify your best path. Here you can see the process behind the 3 need statements that came on top. As you can probably identify, need 1 talks to the alignment within the clinic, while need 2 talks to the lack of a unified discharge tool. Once we identified these needs, we proceeded to select the one to intervene. To do that, we consulted with staff, we reflected between ourselves and our advisors, and we were able finally to access the client voice through a patient advisory committee member and repeat bridging client. From that process, we ended up selecting the need to have a unified discharge tool. Now, Mona will talk to you about the planning and execution of such intervention.
Thanks, Andres. So after the need verification, we moved to ideation, design, and implementation of an intervention. We used a couple of tools and strategies that I explain each in the next few slides. We designed a short survey to capture the bridging client's understanding of their discharge process. It is also a baseline measurement to evaluate the impact of our intervention later in the prototype testing phase. The first iteration of the survey was self-administered. However, once we got incomplete forms, we changed our strategy, and one of the team members would go to the clinic and ask the clients to fill out the form together while they were waiting for their visits. During these iterations, we realized that the discharge word is not clear to clients, so we changed the language around the discharge plan. As you see, the question about the discharge plan extended to other phrases like goal setting and a future vision after bridging. Interestingly, more clients answered yes to revised questions. 96 surveys were collected in total, and 53 were completed and included in the analysis. From 32 self-administered surveys, only 4 agreed that a discharge plan was communicated to them. However, after the revision, 11 out of 21 clients answered yes to at least one of the questions about knowing their discharge plan, goals, or visions. And from those 11 clients, only 2 answered yes to the question using the discharge word. So we concluded that the language used in discharge plan communication should be carefully considered. The key learning here was making sure clients' leadership and staff are on the same page about what discharge means. Next, we conducted a series of ideation activities to create a prototype. We adopted a version of the opportunity canvas and used it with the leadership team to identify the opportunities for unified discharge process. We also had an ideation workshop with different staff groups using brainwriting techniques. Finally, the 4 of us gathered as a team and brainstormed on all the data we gathered and prototyped a unified discharge plan. This is the opportunity canvas that the leaders of bridging completed together in a 1-hour discussion. The values that they agreed in a unified discharge plan were communication, accountability, collaboration, and transparency. Then we had an ideation session with representatives of other staff groups. As you see in this slide, we had a great engagement and contribution. We chose the top 2 ideas that a staff voted on, plus an idea from a physician participant. We decided to include the 3rd idea after the physician discussed it with the group and they agreed on it. The 3 ideas for unified discharge process evolved around including the client's treatment goals and the communication of the 3-month mandate of the clinic. After considering all data and insights, we made a prototype in an iterative manner. This is the 6th version of our prototype you see. This is a client-faced goal setting and tracking form, which would be discussed and filled with the collaboration of clients and providers at each visit and followed up on the next one. We integrated communication, collaboration, accountability, and transparency in this form, which is aligned with the clinic's values and desired outcomes. Some of the changes, according to the feedback from the stakeholders, are highlighted here. They're mostly about changing some of the communication language used for the clients and changing the deadlines from a hard date to a more flexible timeline. For the key learning, we learned how to adapt tools to our needs and audience, such as Opportunity Canvas, Big Ideas Board, and a SMART Goals framework. To develop and implement a final intervention, we need to test the prototype. To do so, we plan to pilot the prototype with 1 clinician, 1 physician, and at least 5 new clients in a course of 3 months. Then the prototype will be evaluated and improved through PDSA cycle, which includes defining an objective, running the test, collecting and analyzing information, and making improvements until reaching the desired outcomes. I'll now hand it over to Dorothea to talk about the impact of our project.
Thanks, Mona. So overall, the main impact that we hope our project will have is a more unified discharge process with a realistic, sustainable bridging plan that will help clients transition to their next service. We felt it was important to have stakeholder input at every stage so that the intervention that we came up with would be valuable and helpful for them and not add unnecessarily to the staff workload. We also wanted our intervention to be sustainable beyond our work with the clinic, which meant we would need staff and leadership buy-in in order for it to be successful. By engaging with the leadership team throughout the capstone, we were able to shadow staff members and gain access to clinic materials for our needs analysis report. Throughout our project, we maintained a flow of communication and felt as though the clinic leadership really were our champions throughout the project, and we appreciate the great relationship that we built with them. We also wanted to understand the staff perspective and their perceived areas of opportunity, so we engaged with them as much as we could during the needs analysis phase and during the need verification. During the intervention and prototyping phase, we conducted the ideation session with them, and the prototype was born directly out of the most highly voted ideas. Trialing the prototype with them and getting feedback is key to successful implementation. Client feedback is also very important to the success of this intervention. Through the client survey and future OPOC surveys, we hope the clinic can gain insight into client perspectives on this tool. The prototype was designed with clients in mind to get them more involved in goal setting and to improve the consistency between each of the staff that the clients are seeing. So as my teammates have talked about during the presentation, we have 5 key learnings we felt were important to share. The first is the importance of engaging with the environment. By becoming research students at CAMH, we were able to shadow clinic staff and observe the ecosystem, which allowed us to form our own opinions instead of relying solely on secondhand accounts. It also allowed for a seamless ethics approval as we had gone through the rigorous ethics training that CAMH provided to us. The second is to be flexible and don't be afraid to pivot and iterate on strategies that aren't working, something that we did multiple times throughout our project. By switching strategies with staff from brainstorming to brainwriting, we were able to achieve much higher levels of engagement. When handing out the client survey with the screener form did not prove successful, we switched to having a team member at the clinic asking the clients the questions, which resulted in much better data output. Our third learning is to narrow the focus. Although it's tempting to give in to scope creep and try and address many problems at once, we learned it's important to focus on changing one thing at a time for the greatest chance of success. The fourth is to build your toolkit and adapt tools to fit your needs. We used a variety of tools that were recommended to us by our advisors or found through research. However, we also took the initiative to modify these tools to our own needs. For example, we used the Opportunity Canvas framework with the leadership team to understand what they hoped to get out of an intervention, but we modified the headings to fit our needs and get the information that we were looking for. We also used the SMART goal framework in our roadmap to bridging prototype. But after receiving feedback from staff that one specific date may be stressful to clients and staff, we modified this field to be more flexible. And finally, our fifth learning is that language matters, and it's critical for clients, staff, and leadership to all be on the same page when it comes to terminology. A very important finding from the client surveys was that clients understand the concept of goal setting, but not necessarily the word discharge. So if you recall the definition of continuity of care that we shared at the beginning of our presentation, continuity of care is described as the degree to which a series of discrete healthcare events is experienced by people as coherent and interconnected over time and consistent with their health needs and preferences. The purpose of Roadmap to Bridging is to strengthen the client-provider relationship and improve continuity of care by providing a comprehensive and consistent way to discuss goals. We first conducted a root cause analysis which verified the need for a unified discharge process. We then developed and refined our intervention through iterative cycles of feedback from clinic leadership and staff. Through client surveys, we learned that the term discharge was not well understood, an important insight we shared with the clinic. With all this, we arrived at Roadmap to Bridging, a client-facing forum with built-in accountability to help document goal-setting discussions between clients and staff. Through our forum, we aim to help clients flow through the clinic more efficiently, thereby decreasing the backlog of discharges, which will allow the clinic to take in more ED diverts and ultimately support more clients. And finally, in addition to our advisors, we would also like to thank the Bridging Clinic leadership and staff teams for welcoming us into the clinic and sharing their insights and knowledge with us. We hope we were able to give you an overview of our project in the past 20 minutes, and we welcome any questions you may have for us.